Good morning, bonjour. My name is David Moore. I'm from the University of British Columbia, and on behalf of myself and the co-chair of the Epi and Public Health track, Elaine Trottier, we're pleased to introduce Dr. Anne Burchell, who will give our plenary for this track this morning. Of course, Dr. Burchell is well known to CAHR. She's a scientist in the Department of Family and Community Medicine and the Center for Urban Health Solutions at St. Michael's Hospital in Toronto. Her research program is funded by a CIHR Foundation Award and focuses on the epidemiology of HIV infection, HPV, syphilis, and other STIs, with an emphasis on primary and secondary prevention. She has extensive experience in observational longitudinal studies, sexual behavior, and high access questionnaires, health access questionnaires, natural history studies using laboratory markers of infection, and most recently, pragmatic randomized trials for HPV prevention and improved screening for syphilis, cervical, and anal cancer. So won't you please join me in welcoming Dr. Anne Burchell.
Thank you very much, Dr. Moore, and also to Dr. Trottier, to Alexandra de Pocomandi, and to CAHR for inviting me to come and speak with you today. I'm deeply honored. It's such a pleasure to be here in Montreal, where it's like a second home. It's where I did my PhD at McGill. And at the risk of dating myself, I have been coming to CAHR since 1995. So it's really nice to be up here on this side of the podium to give this talk. I have no conflicts of interest to declare for this talk, but I do want to acknowledge that I work with an amazing group of very smart people from across the country, really wonderful staff and trainees and collaborators. And in particular, I want to point out Ramandeep Gruel and Jyoti Rana, who helped me with preparing some of these slides today. So I'd like to begin with first orienting us to the schematic that we all should have fairly well memorized by now, the HIV care cascade. And these are the estimates most recently put out by the Public Health Agency of Canada for the number of people living with HIV in Canada, thought to be around 65,000 people, of whom about 80% are diagnosed, and it's thought that about 50,000 are on antiretroviral treatment. And among the people who successfully navigate care and get onto antiretroviral treatment, most have viral suppression, which is a good thing, meaning that their HIV infection is well managed. But I want to talk about other infections. So for well over a decade now, there have been these media reports about increases in other sexually transmitted infections besides HIV. A lot of talk about syphilis and also gonorrhea. And the media reports keep coming. They talk about increases upon increases, or at least sustained high infection rates. And this most recent report coming out of Montreal about a year ago, talking about an explosion in STD infections. And a lot of these media reports refer to the fact that a lot of these case reports are being observed in communities of gay men and other men who have sex with men, many of whom are co-infected with HIV. So I want to spend some time exploring the evidence for that. I want to talk about the epidemiology of STI co-infections among people living with HIV, and then spend a good deal of time talking about what we could do about that in terms of testing and really optimizing the way that testing for these infections is delivered. I'm going to tell a few stories. I'm going to first talk about the bacterial STIs, syphilis, gonorrhea, and chlamydia, and then I want to end with a story about human papillomavirus. So let's start first with the bacterial STIs. Here, these are the national rates of reported infectious syphilis shown per 100,000. And the story that slide is telling you is that since about the year 2000, there's been a dramatic increase in the rate of syphilis, which was really had gotten quite rare in the 90s. And that rise in infections has largely been among males, shown in purple, compared to women, shown in the teal color. And now I'm superimposing the rates for Toronto over the national rates, and I'm doing this for a few reasons. So first is to point out that in a large urban center like Toronto, which happens to be where I work and where I know the local epidemiology best, the rates are much higher than the national average. But the pattern is largely the same in urban centers, namely that most of the transmitted syphilis, if not all in some places, is among males. It's not entirely true everywhere in Canada, though, so I do want to just mention that there are some places in the north and in the prairies where there has been outbreaks of heterosexually transmitted syphilis, but in the urban centers, this is really an issue among men. And a lot of those men are reporting sex with other men, and many are co-infected with HIV, so 45% of male syphilis cases in Toronto in 2015 had HIV co-infection, quite more than we would have expected based on the background rate of HIV, which the prevalence of which is thought to be about 20% among MSM in Toronto. So now turning to gonorrhea. So we're seeing a rise here nationally in reported cases among males and among females. But if we start looking a little more closely, certainly in Toronto, much more dramatic increase in the males than among the females, and 60% of male cases in 2015 reported sex with other men. Now to chlamydia. The story of chlamydia is a little bit interesting. It's a bit layered. So with chlamydia, the reported rates nationally are higher among women than they are among men. A lot of those chlamydia cases are among young women in their teens and in their 20s, but the rate is going up among men. And in Toronto, for example, the increase in chlamydia is more dramatic among the men than it is among the women. And among male cases by 2015 in Toronto, about 1 in 4 were men who reported sex with men. And then if we look at a particular strain of chlamydia that causes lymphogranuloma venereum, or LGV, which is a more severe condition caused by these particular strains of chlamydia that require a longer course of antibiotics, we've seen a dramatic rise in the number of LGV cases. These are data from Ontario. Most of those cases were in Toronto, and Troy Grennan gave a very interesting talk yesterday in the EPI session in the afternoon showing a similar pattern in BC. So of this recent quite dramatic rise in LGV cases, all the confirmed cases were male, 90% were men who have sex with men, and 65% were co-infected with HIV. So what these surveillance statistics are starting to tell us here is that there certainly has been an increase in these bacterial STI infections. A lot of the transmission seems to be happening in the communities of gay and other men who have sex with men, and a lot of the transmissions have been occurring among HIV-positive men. That's based on the information coming from the cases, but we don't yet have a clean denominator of just among HIV-positive men who have sex with men. So let's start to take a look at that. In this graph, what I'm showing you is results from studies from around the world that have estimated the prevalence of chlamydia, shown in blue, gonorrhea in red, and syphilis in green. And I've highlighted with dashed lines where Canadian data are coming from. So there's a few Canadian studies that have been published here. One, a study in Toronto published by Robert Remus and Rupert Call and colleagues, and 2 studies from my own work from the Ontario HIV Treatment Network cohort study. That's a multi-site study, an HIV clinical cohort, people attending HIV care in specialty clinics, mostly hospital-based outpatient clinics. And what we see here is that the prevalence of these infections is certainly far from rare, and that what we're finding in Canada is in line with what we're seeing internationally. Incidence, of course, is more informative, I think, from an epidemiological perspective. It helps us understand in whom and where and when these infections are being acquired. We are able to estimate the incidence of a new syphilis diagnosis using data from the OHGN cohort study in the subset of men who have sex with men who are HIV positive. And I've superimposed those rates, they're shown in blue, over the general population rates for males, shown in purple, from Toronto. And I want you to notice the vertical axis, the scale has been changed. It's now logarithmic, because the rate of syphilis diagnosis among HIV-positive men who have sex with men is several-fold higher. It's about 2 to 5% per year, much higher than the male general population. But if we look at international data, still in line with what has been observed internationally when we focus in on cohorts of HIV-positive MSM. So that's shown there in the green diamonds, or triangles, I should say, and with the dashed lines, the estimate coming from the OHTN cohort study. I've also shown you there the estimate of incidence of a new diagnosis with chlamydia or gonorrhea. And in the OHTN cohort study, that estimate was coming in at between 1% and 2% per year. Now, importantly, those Ontario data are underestimates of what the true infection rates are likely. These are diagnosis rates for a few reasons. Number one, in that cohort, not everybody was tested. The tests were done for clinical care purposes. So in all likelihood, if everybody had been tested, the rate would have been a bit higher. Also, for chlamydia and gonorrhea, almost all testing in that cohort was urine-based. So for those two pathogens, if you just do a urine test, you only detect urethral infection. And it's thought that if you don't swab the rectum and also do a pharyngeal swab, you could miss at least 70% of these cases. So by now, I should have shown you enough epi-stats to convince you that the rate of these infections it's not insignificant among HIV-positive men who have sex with men. So we want to start thinking about ways we might be able to target interventions. So we've taken a look at this in the OHTN cohort study, and we certainly have found that younger men are at higher risk. So we find that a new syphilis diagnosis is more likely among men under the age of 30 at about 10% a year. But if we just focus on the young guys, we're going to miss things because the rates are still high among the older men. Even among men aged 50 and older, about 2% a year are getting a new diagnosis of syphilis. Now, if we look at sociodemographics, we did find that the higher rates of syphilis diagnoses were in the urban centers, just like that the provincial statistics would indicate, and they were higher among the better educated men. But we didn't see a lot of variation by ethnicity or by income, and the rates were non-negligible outside of the large urban centers at about 1% a year. Another way we might want to think about targeting interventions would be to what's sometimes referred to as STI repeaters in literature, so that the idea being that people who have an STI once might be at higher risk of getting it again, so we could maybe dedicate our intervention effort to them. And certainly, men in this cohort, if they'd had syphilis before, they were nearly 4 times more likely to get it again. But in 2015, we did find that 40% of new syphilis diagnoses were among men with previous non-reactive serology. We've also spent some time taking a look at behavioral risk factors for the diagnosis with these infections, because of course that's the way people get these infections, through sexual behavior. So what are the sexual behaviors that are associated with them? And we found some consistency here with a new diagnosis of urethral, chlamydia, or gonorrhea, or with syphilis, in that men who report multiple partners are more at risk, particularly if they report multiple HIV-positive partners, so if it's positive men with other positive men. Also, if they engage in anal sex, there didn't seem to be a big difference in risk according to whether or not you always used a condom or sometimes had some condomless anal sex, and also a doubling of risk if men reported recreational drug use. So I looked at that a little bit more closely, this issue of serosorting, and looked at subsequent cumulative incidence of a new syphilis diagnosis according to the HIV status of men's partners as they reported at their first sexual behavior questionnaire. And the highest risk within 24 months of having a diagnosis of syphilis was among men who reported multiple partners who were a mix of HIV negative, HIV positive, or status unknown, at about 17% by 24 months. But the next highest risk was among men who reported only other positive partners, much higher than among men who reported only negative partners. but still the risk of a syphilis diagnosis was still around 5% at 24 months among men reporting only negative partners. So I'm showing you now this quote that was in an editorial written by Matthew Golden and Hunter Hansfield, because I think it sums up well some of the issues that have been raised by the data I've just shown you, and also some hypotheses around what might be going on. And they speak of this explosive increase in bacterial STI among MSM, that it's an unintended consequence in all likelihood of our success in fighting HIV, which is a fabulous success story, and it's not to take away from that, but suggesting that some of the seroadaptive changes in behaviors that may have happened there to minimize HIV transmission risk have created this potential for transmission of bacterial STIs. The other piece that comes out in that quote that I think is worth noting is the second part around being in the STI prevention community and feeling that we're dealing with an out-of-control STI epidemic, and a lot of people wondering, what are we going to do about this? What's our plan forward? And a little bit of kind of discouragement about what to do. Well, in my first opening slide, I showed that diagram, that figure we all know, the HIV care cascade. And there's also a cascade for STI prevention and control. This one comes from the WHO and their strategy on STIs. And it's the same kind of idea. It's been around a lot longer than the HIV care cascade, actually. The idea being that if we can get people who have an infected STI tested in a timely way and then treated, we could create or have a much better control of these epidemics, because we would not only prevent the adverse health outcomes among people who get infected with them, but we could prevent transmission to partners. So this could be a helpful framework of thinking about the way forward and what interventions that we could do and how we might be able to implement them along all these steps. But I'd like to remind you, as we start to think about potential interventions, the data that I shared with you before really didn't identify one particular sociodemographic characteristic or behavior where all the risk was. So these epidemics are in all likelihood broadly disseminated, and we're going to think really comprehensively about how we might deliver better testing services. So now I want to share with you a little bit about what the current testing patterns are, so we can think of where there is room for improvement. And I would suggest that there is. These are data, again, from the OHTN cohort study among the HIV-positive MSM in that cohort. And I'm looking here at the proportion of men who had at least one syphilis test done in each year. And according to the Canadian STI guidelines, that would be recommended for sexually active MSM. So the rates of having a syphilis test are definitely going up. That's good. We still have a little ways to go. And in those guidelines, it suggests for men who are at ongoing risk, they should have a test done more often than once a year, as often as every 3 months. And certainly in this cohort, among the men who tested, the average interval between tests was about 1 to 2 years. So let's talk a little bit about being at ongoing risk, because maybe the men who aren't getting tested, well, they're not sexually active, they're at low risk, they don't really need a test anyway. So I tried to operationalize this based on the number of partners that men reported, and broke that down by what they reported at their baseline questionnaire and look forward in time, and looking at rates of a new diagnosis of syphilis in blue or chlamydia and gonorrhea in red over an average follow-up period of about 1 3/4 of a year. And, sorry, not a new diagnosis of these infections, whether or not they were tested, and found that the more risk that men had, the more likely they were to be tested for these infections, so that's good. But still among men reporting 5 or more partners, many of them had not been tested for syphilis, half had not been tested for chlamydia or gonorrhea. So why might that be? The data from the cohort study can't really tell us, but here's data from another study, the Sex Now survey. It's an internet survey that men who seek men can fill this questionnaire out online. And it's not just for HIV-positive men, it's for all men who have sex with men. Nathan Lachowski was very kind to share these data with me so I could share them with you today. And what I'm showing you is the response men answered to the question, have you told a healthcare provider that you have sex with other men? And most men did, 63% of them did, but that means 2 out of 5 didn't. So that might be something we want to think about in whether or not men are actually getting tested. So in thinking about the potential interventions that we might do, certainly there's room for improvement. We'll need to get innovative, and we'll need to do it in a way that's non-stigmatizing to men, or to anyone who's sexually active for that matter, and is acceptable. So I'm going to talk about a few examples of clinic-based interventions that have some evidence for effectiveness in the literature, and also an alternative to clinic settings. So the first intervention I want to talk about is one that is streamlining or routinizing test experiences. It's a very interesting study from Australia, from Melbourne, where the idea was among people in HIV care, they're already having regular blood work done, and at the time this intervention was done, they were getting HIV blood work done every 3 months. So they introduced an opt-out routinized syphilis intervention where the paper lab requisitions for HIV blood work had syphilis serology automatically stamped on them. And in their pre-post intervention comparison, they found that they had a dramatic increase in the proportion of patients who had syphilis testing done. They increased their case detection of syphilis, and a lot more of their syphilis cases were asymptomatic, meaning that they wouldn't have been found through usual case finding based on presentation. Now, in Ontario, we, working with co-principal investigators Vanessa Allen and Daryl Tan and a great group of colleagues, we thought, we should really try this here, but we wanted to improve the design with a randomized concurrent comparison group. So we have a trial underway right now that's funded by CAHR and the CTN, and we're actually trying to do this in 4 hospital HIV clinics in Toronto and Ottawa. And unlike the previous work that has been done or other studies on this intervention from the UK, we're including a cost-effectiveness component, so we'll be able to see whether this is a good, there's a good value for money in trying this. So the trial will end in this summer, and I hope at next year's CAHR we'll be able to share results with you. There are some potential other clinic-based interventions we could explore. So here's one from London, where the idea was to do automated reminders to patients, and they tried text reminders for people who had an STI to get them to come back into the clinic for reattendance. So perhaps a strategy to try to get people into the habit of testing regularly. And they found a benefit of text reminders to patients, but only if the text reminders were personalized. So using the patient's name really mattered. Another potential intervention could be trying to facilitate risk stratification of who might need a test, and then use EMR reminders to flag this to providers. So in this intervention in Melbourne again, what the investigators had men do was, in the waiting room, they filled out computerized questionnaires about their sexual behavior, and if men answered that they had 10 or more partners in the past year, that generated a flag in the patient's EMR record, recommending to the provider to offer syphilis testing, and they did find an improvement in syphilis testing and also detection of asymptomatic syphilis. One more clinic-based intervention I want to share with you is thinking about the ways that people provide specimens. So in particular for chlamydia and gonorrhea, it's really important to not just get urine, but to also get swabs of the rectum and pharyngeal swabs, because you'll miss a lot of cases if you only do urine. So in this HIV clinic in Seattle, what they did was they set up this self-testing room with lots of visuals and instructions and questionnaires for men and women to figure out whether or not they should self-collect a specimen. And they found that by doing this self-testing room, they got a lot more patients who were collecting all 3 specimens, and case detection yield doubled. And importantly, the intervention was acceptable to patients. Now, I've been talking an awful lot about what to do, or what we could do in clinics, but we could also start to think about alternative to clinic settings, because if what we do in a clinic is great for people who are already connected to care and in that clinic, but not everybody is, or maybe not everybody is comfortable coming forward. So I want to point out one particular alternative, British Columbia's Get Checked Online program that's led by Mark Gilbert at the BC CDC. It's quite a clever idea that I know he's been working, and BC CDC has been working on for some time to really fine-tune and finesse. The idea is that you go online, you create an account, you answer a bunch of questions, and then you're told, well, you could benefit from this kind of an STI test, and you print your lab requisition for those tests, go into your local life labs, give the specimens, and a few days later, you can go online or pick up the phone to get the result. And here are some recent findings from that program in BC, which show that as the campaign has expanded, the number of people coming forward and completing testing has gone up dramatically, shown in blue, and their case detection rate has gone up as well, shown in red there. So they're getting about 5% positivity with this program. I think it's a really exciting Made in Canada approach, and it's one we should really be taking a close look at and thinking about for scaling up in other parts of Canada. So as I was doing this review of the literature, I need to tell you, I was starting to wonder a little bit about where the Canadian publications were, and wondering, are we really competitive in this area of developing interventions for bacterial STIs? So of course, I'm an epidemiologist, and if I'm going to answer a question like that, I'll count things. So here are counts of publications since 2000 on bacterial STI testing interventions broken down by country, and you can see Canada is there, and we have 3 publications. The United States really is the top performer, but you know, they're 30 times bigger than us, right? That's not fair to compare. The UK is doing well, they're twice our size. Australia is really doing well, they're smaller than us by 10 million people. And a lot of these other countries that are shown there are much smaller than us. So it's not because that people out there aren't actually trying things with bacterial STI testing. I know from going to meetings across the country and speaking to all of you that a lot of clinics and public health units are trying stuff. But we could do better in evaluating it and publishing it. So now I want to speak directly to the trainees and new investigators in the room. If you're thinking about things you might do in your career as you expand your research program, here's an area that has a need and there's a gap. I now want to switch gears a little bit. I've been talking about the bacterial STIs, syphilis, chlamydia, and gonorrhea, for which we have guidelines. We have guidelines about who to test, when to test, what tests to use, and if people have a reactive result, what's the treatment and follow-up management for them. I want to now tell a story about human papillomavirus, where the guidelines for what to do in terms of testing and treatment are incomplete. So human papillomavirus is an important virus because it's a cancer-causing virus. And worldwide, it's thought that about 15% of cancers are actually attributable to infectious agents, and about 1 of 3 of those cancers are caused by HPV. The cancer that HPV is most known for and notable for is cervical cancer. It's thought to cause all cervical cancers, over 500,000 of them every year worldwide. But after that, anal cancer is the anogenital cancer with the highest attributable fraction by HPV. So let's think a little bit about that story. HPV is an extremely common sexually transmitted infection, regardless of your sex, gender, or sexual orientation. But it's particularly common among HIV-positive men who have sex with men, particularly in the anal canal. And I'm showing you here results from international prevalence studies of HPV infection in the anal canal, and the dashed lines are indicating the results from work done right here in Montreal by Alexandre de Pocamandi. In the blue diamonds, it's showing the proportion of men with at least 1 HPV type infection. So there's about 40 different HPV types that are sexually transmitted, and it's almost 100% prevalence among HIV-positive men who have sex with men. Most of those types, though, aren't cancer-causing. We're more concerned about the high-risk types that have potential to cause cancer, and they're shown in red, where prevalence is around 25 to 90%. And of those high-risk types, HPV-16 is the worst offender. It causes the most cancers. And in Alexandre's work here in Montreal, that was nearly 40% prevalence in the anal canal. But even so, most of those infections don't cause cancer, so it's not a huge cause for alarm. Most of them do clear on their own. It's important in that, to think about what's the actual risk of cancer. And these are data from France, which show that the bottom part of the graph, rates of anal cancer per 100,000 it's a fairly rare cancer, only 1 per 100,000 per year. But among people infected with HIV, the risk for anal cancer goes up dramatically. It goes up 30 to 100-fold, likely because having the HIV infection there makes an HPV infection, if one acquires it, that much more likely to persist, to progress to a lesion, and for that lesion to not regress naturally. And in particular, these rates of anal cancers are highest among the HIV-positive men who have sex with men, with estimates around 100 per 100,000, but still high among other men living with HIV and also among women living with HIV. So that by age 75, it's thought that the lifetime risk of an anal cancer for people living with HIV is almost 2% compared to 0.1% in the general population. Well, there's things we can do about another cancer caused by HPV, cervical cancer. For decades now, there have been cervical cancer screening programs in place with Pap cytology, and these are slowly moving to HPV testing, so that in places where cervical cancer screening has been put in, and there's good coverage and good follow-up of detected abnormalities, cervical cancer rates have declined precipitously. It's true for the data I'm showing you here in England and also in Canada. And if we were, say, among HIV-positive women to do a test in the cervix as well as in the anus, we would find that HPV-associated abnormalities are actually more prevalent in the anus than they are in the cervix. This is work from here in Montreal in the EVA cohort study led by Alexander de Pogamundi again. So perhaps I suggest to you we need to be paying a bit more attention to anal health. And there's a lot that we might be able to learn about cervical cancer screening and apply that to anal cancer screening. I'm not the one to have come up with this idea originally. There are a number of people from around the world who are taking a look at this and thinking about how we might be able to do anal cancer screening right. And I'm happy to tell you that Canada is one of the leaders in this area, as well as with projects being done in the United States and in Australia. Troy Grannon and Urs Salad are leading this work with the HPV Save Team grant. So we don't yet have anal cancer screening guidelines, but this is, I think, a work in progress. Work is being done to try and figure out and establish an evidence base that could inform such guidelines, including looking at the natural history of infections and the lesions caused by them, trying to figure out what are the right screening tools to use that will have good performance, good sensitivity and specificity. And also, what do you do with those lesions when you find them? Do you immediately remove them, or is watchful waiting more appropriate? There's actually been 2 presentations at this conference around work around this from the HPV Save grant, including a presentation yesterday by Troy Grannon and a poster by Jennifer Gillis. There's another piece, though, we need to think about in terms of whether we should introduce screening, and that is, would this kind of screening be acceptable to the population? I think that's always an important thing to be thinking about for any population. It's certainly important to be thinking about for people living with HIV. So we wanted to take a look at that, and this was a collaboration between HPV Save, coming back to the OHGN cohort study, where we administered a series of questions around HPV and cancers caused by HPV to men living with HIV in the cohort. And the first question we asked the men were, have you ever heard of HPV? And nearly half of the men either said, nope, they'd never heard of it, or if they'd heard of it, they didn't really know what it was. And among the men who did say they'd heard of it, many of them, when asked a series of true-false questions about HPV and the diseases it causes, didn't know a number of the basic facts. We also asked men what they thought their perceived risk was of getting HPV, warts, or anal cancer. And the majority of men thought their risk of getting HPV was no chance or low chance. And of course, I've already shown you that graph that HPV prevalence is extremely high and approaches 100%. Also, many thought they weren't at risk of anal cancer. Now, I mean, it is still a rare cancer, even among people with HIV, but it's definitely elevated among people with HIV. And in particular, the older men were more likely to think they were even less at risk. And it's in that group, the older men, where if we did have anal cancer screening to offer, that would be a group that should be at the front of the line. Because if there was an HPV infection causing a lesion there, that lesion has had that much longer to progress, possibly to cancer. Another question we asked was how comfortable men were in talking about matters of their anal health with their doctors and also with other men. And what we found was that these men said that they're actually very comfortable talking to their doctors, whether it's their primary care doctor or their HIV doctor, and not necessarily because they were comfortable talking to everybody about anal health. And men were far less likely to feel comfortable talking to other men about it. And this was true, this comfort in discussing it with their doctors was even true for the heterosexually identified men. Interestingly, when I shared these data with some primary care providers a few weeks ago, we did like a clicker exercise to ask them what they thought the answer was going to be ahead of time. Most primary care doctors in the room thought men would be really uncomfortable talking about this. So I think these are interesting findings. We also asked the men about their previous experiences with anal tests, and most actually have had experience with this, particularly for digital rectal exams or a rectal swab for STIs, and many men have already had an anal pap or an anoscopy. And finally, we asked about willingness or future intention to undergo anal cancer screening if it were offered to them. And we found that most men said they were likely or very likely to have any of these kinds of anal cancer screening modalities that might be considered for anal cancer screening. Now, importantly, in HPV Save, the next step is actually offer men screening, and we'll be able to look to see what proportion actually do uptake screening, and are there characteristics of men associated with a hesitancy to uptake screening. So there are implications, I think, of these findings for what we could do going forward in thinking about the potential for implementing anal screening as guidelines emerge. Certainly, any such initiative is going to need to think about educational campaigns and improving literacy of men around HPV and its associated diseases. At least among a group of men who are in HIV care and well retained in HIV care, men seem to be comfortable talking about issues related to anal health with their doctors and generally willing to accept anal cancer screening. So that bears well. Some of you may be wondering about, what about women? And I think that is an important thing to be thinking about as well as this evidence is accumulating. And I want to draw your attention in particular to a poster here at this conference by Joanne Lindsay, Joanne is taking a community perspective of these issues of HPV and HPV-associated diseases among women. So I encourage you to check it out. So in closing, I'd like to leave you with a few thoughts. In keeping with the theme of the conference, we're not done yet. I think that's definitely true for bacterial STIs. Those rates are high and they're not coming down. But there's reason to be optimistic about that. I mean, these infections are treatable, and there are ways that we can deal with them through testing. The testing, there's room for improvement, but there's lots of things we can try. And there's evidence from other places about interventions that could help. In terms of HPV and prevention of its associated diseases, we're really fortunate to have a vaccine that's being implemented across the country for young girls, and more provinces are coming online with universal male vaccination. But it's going to take decades for the protective effects of vaccine to trickle down to where we'll see real change in cancer rates. And the adults today, the vaccination being done in schools is not going to help them. So we do need to be thinking about screening and having evidence-informed screening, possibly for anal cancer. And there's a lot of different approaches that can be tried, as I mentioned, and I think it's really important not to focus all our efforts in just encouraging people living with HIV to initiate testing and screening, but to think about ways we can intervene at the provider and clinic level and even the health system level to deliver these services better within programs of comprehensive sexual health care. And then the last thought I want to leave you with is all this good work that I know many of you are doing. I think it's so important that we rigorously evaluate it and publish it so that we can share it and learn from each other from across the country. Thank you very much for your attention.
I think, do we have time for a few questions? Yes? Anybody wants to? Just while maybe some people are coming to the microphone, I had one question. What are your thoughts about prophylaxis for bacterial STIs, particularly amongst HIV-positive MSM?
That's a good question, and one that a few years ago I would have been very hesitant to have said do that, but I have changed my mind a little and thought certainly with the success of HIV PrEP, there may be, this may be an idea to try for some people at especially high risk of syphilis reacquisition. So there was a trial that was reported a couple of years ago, a very small trial showing a potential benefit for daily doxycycline use. Troy Grennan is leading a project, as well as Mark Hull, I believe, in BC to actually try this and take a look to see whether it could have some benefit, again, in very high-risk populations. The big fear, of course, is antibiotic resistance, and I think that has to be established and investigated quite closely before we would start recommending this to make sure it doesn't have any deleterious impact on the microbiome.
Good morning, Anne.
Good morning, Tyler.
Yeah, I have a disclosure. I'm Anne's PhD student, and she did not approve this question. I do have a question, though, about bacterial and viral STIs and incidental increases in incident diagnosis among men in large urban centers in the United States, so New York, Los Angeles, San Francisco, with the advent of PrEP. And I'm wondering, from your perspective, from a STI co-infection policy and clinical recommendation guideline, what your stance is on the use of PrEP to increase the number of individuals who are getting diagnosed with these co-infections when they go in to get a PrEP prescription, or to be on PrEP to then subsequently get diagnosed sooner.
Right. So I think we have to keep distinct. People who go on HIV PrEP are negative, as opposed to what we might be delivering to people already living with HIV. And certainly it's been documented that a lot of people who've gone on HIV PrEP are having high rates of bacterial STIs. And indeed, a lot of the determination of who's gone on HIV PrEP has been because you needed to have already had a recent bacterial STI to be eligible to go on. So those are exactly the people that you'd want to go on HIV PrEP, and that's good. And with HIV PrEP guidelines being such that recommending that people have regular bacterial STI screening, that's appropriate, and a lot of those infections are being detected. I do think in some of the language that's, or reports around that, what has been missing for me, all this concern about STI acquisition among the negative people on PrEP, is how that might influence people already living with HIV who are at higher rates of these bacterial STIs already. And I suggest to you that one possibility is that with potential seroadaptive behaviors that have happened because of concerns around limiting HIV transmission risk, and I showed you data indicating that a lot of the risk among the HIV positive guys was from having sex with other positive men. Well, with HIV PrEP, there's going to be less reason to be engaging in seroadaptive behaviors, and people will be more free to make choices about who they want to do and what they want to do with them. So there's a possibility then we're going to see an even greater rates of infection of bacterial STIs in the positive guys. So when thinking about how we want to manage that with HIV PrEP, we need to think about not just the HIV negative people who are on PrEP, but also making sure the people living with HIV are getting access to testing too.
First of all, thank you for a wonderful talk. I learned a lot. So I was just curious, though, you're already talking about behaviors. And so, of course, for someone like me, I'm always thinking about, how can I get in on the mix? Obviously, you want to treat people and get people easy access to care. But is there anything that can be done on the behavioral side? It almost seems like from your data, it was like, well, people can have anal sex, they cannot have anal sex, they can use a condom, they cannot use a condom, and I'm not really sure where we can go if we want to help do sexual health promotion for those of us that work in community and behaviorally.
And I'm glad you're leading research to be looking at that specifically, Trevor. That's true, I kind of left that part out, focusing more on the testing side. I think there is room for interventions and education around behavior. I mean, the usual things are there: limit your number of partners. And there is evidence from other places that condoms can limit infection and transmission for these bacterial STIs, and even for HPV for that matter. But the risk of transmission doesn't go down as dramatically as it does for HIV, because these infections can transmit in other ways. So certainly they can transmit through oral sex. And if there's any contact before a condom is put on, that kind of thing, these infections are much more transmissible than HIV. So I think there is room for behavioral interventions, but also we have to recognize for some people that they're going to choose to engage in sexual behavior, and that's where I think that it's important to have the testing services available to them in a lot of different ways, so that people can come into it from multiple approaches.
Okay, well, I think we're out of time, so can you all please join me in thanking Dr. Burchell for your presentation? Thank you. There you go.